So there, it's Claire Snowden here. I'm one of the chairs of the MRC for Trials Methodology Research Trial Conduct Working Group. And it's really a nice thing to know that you're all here and to welcome you to one of our webinars. The webinar today is going to be presented by Will Cragg, who's a Research Associate in Trial Methodology Conduct at the MRC Clinical Trials Unit at UCL. He's based in the Institute of Clinical Trials and Methodology, so a very interesting place to be. He has previous experience in a number of trial management and data management roles, so he's got a lot of experience in all sorts of trial conduct challenges, which he'll be drawing on today. And he's now looking to address issues around monitoring of clinical trials, which is clearly a very important challenge. He first started to work on the TEMPA study that he's going to tell us about today as a monitor, but since 2016 he's taken on a research associate role within the team. So he's going to be able to tell us about that research element today, about the TEMPA study. And the TEMPA study has evaluated an approach to monitoring, which is very interesting, in which sites are prioritised for monitoring visits based on the information that comes in from central monitoring. So we're going to hear about the study results and the implications, and we're going to think about where next for monitoring, given what's been learnt from this study. So I'll hand over to Will now. Thank you, Will.
Originally at the Society of Clinical Trials meeting back in Liverpool in May. So I'm talking on behalf of the study team, and I'll show the names at the end. Let's start with a slightly leading question, which is regular on-site monitoring always appropriate in clinical trials? I think there's a growing recognition that possibly it isn't, borne out in various regulatory developments more recently. Hence the rise in the last few years of this concept of risk-based monitoring, where we base our monitoring processes on the risks that are inherent and specific to each trial. We have a problem though, which is that we don't have evidence to back up the best methods for risk-based monitoring, and this is where TEMPA tries to come in. In TEMPA, we're looking at one alternative method to the regular on-site monitoring method. We've called it triggered monitoring, and it's similar to what's elsewhere called targeted monitoring. So each trial would have a risk assessment done where we find out the main risks and put in place mitigation strategies. We would review the accumulating central monitoring data and choose the sites that seem concerning to us, and then prioritize these for visits. In some situations, that might mean we visit these concerning sites and we don't visit the other ones, or in another situation it can be that we just visit these sites first because they seem concerning. We believe it's a widely used strategy, and targeted monitoring, as it's worded, is now mentioned in the revision to ICH TCP guidance. But as I say, we don't have evidence to back up the best way to use this. So the primary question in TEMPA: does a targeted on-site monitoring strategy help us distinguish sites with a substantially higher rate of serious finding when we go to those visits? We have some secondary questions to look in a bit more detail. Which data triggers are most useful? And can we find out anything else about the sites that might predict what we're going to find at visits? A little background to monitoring at the MRC Clinical Trials Unit. We run a variety of trials, and these obviously between them have a variety of different risks, and therefore we have a variety of strategies, monitoring strategies are used. Some trials do have intensive on-site monitoring where that's required. Other sites do use risk-based monitoring, certainly more recently. We have, prior to TEMPA, we found there was a series of trials that had quite well-established triggered monitoring practices. Often they were academically sponsored, often with many sites making intensive on-site monitoring quite difficult. In any case, for all of our trials, the monitoring plans are based on the risk assessments, and both documents are reviewed by internal standards committees. This is a brief overview of the schema of TEMPA. So we took clinical trials that were already using a targeted monitoring strategy. We didn't set a limit on the number, but in the end that was 3 trials. We worked with those trials to identify sites that had an overall high trigger score, as we call it, and so probably would deserve a visit. We then used a matching algorithm to pair each one with a site with a low trigger score, which wouldn't normally be a priority for a visit. We visited all of these sites as per the study monitoring plan, so they had the same kind of visit. And then we compared the proportion of sites in each group with at least one critical or major finding, CM, critical or major finding, between those not triggered and those triggered. Secondarily, we've looked also at the total number of critical and major findings amongst a couple of other secondary outcomes, which I'll talk about shortly. Some issues to do with design and implementation. As I mentioned, we looked for eligible trials as well as already running a targeted monitoring strategy. We wanted them to be in recruitment or follow-up for the duration of the TEMPA visits for obvious reasons. We defined data triggers with the teams based on current practice, and that's an important consideration when thinking about TEMPA. Before the study, we didn't look for potential triggers. The trials were already using a range of triggers, and we thought we could actually just test those. The sorts of things that I'm talking about, and we'll see exactly what was covered later on, the sorts of things are low data return from sites to sponsor or high or low numbers of SAEs reported. We developed a database application which was critical for making the whole thing work. It collated the trigger data for us, it did the matching, and we also had various reporting functionalities. We're planning to write that up as a separate publication to the main publication because we think it's of general interest, especially if people are thinking about using a targeted monitoring approach. We held approximately 3 monthly meetings with the trial teams to sit down with the trigger data that we'd extracted and choose which sites they thought would be justified for a visit. The matching algorithm looked at similarity in terms of the size of sites, i.e. the number of patients randomized and the time since the first randomization, so the length of the lifespan of the site, if you like. And then match this against the difference in trigger score. We were going for as big a difference in trigger score as possible. We conducted each visit in accordance with each trial's monitoring plan of those 3 trials. They were, however, generally pretty similar, and this is a whole list of abbreviations, so I'll just explain. We have investigator site file checks, consent form checks, pharmacy file and facility checks, and then things to do with source data verification and CRF review. That might be familiar to a lot of people as a fairly typical monitoring, on-site monitoring activities. We used the same TEMPA monitoring report for all visits so that we could get some consistency in reporting. We aimed for visits to take place around the time of the trigger meeting. There were some fairly specific rules. So, for example, somebody's saying my voice is a little quiet. I'll try and talk up. So timing, we aimed, for example, to have all visits relating to one meeting completed within 3 months of that trigger meeting. And we'll see later on how well we did in meeting these timelines. The visits were conducted by a combination of TEMPA monitors employed as part of the TEMPA study and members of the trial team, which I think gave some consistency from both angles, the study angle and the trial team angle. We also had pre-visit site and clinical trials unit questionnaires. I mentioned earlier about site characteristics. These were our methods to try and gauge those site characteristics, and I'll explain more about those later as well. This is an overview of our classification. Most people will be familiar with this critical, major, other 3 levels. And here we presented just the sorts of things that would be in each level. I would point out in particular at the bottom of the critical and major categories, you'll see that we have an accumulation of the level below. So if there's a lot of other findings, they become one major finding. In practice, this was really specific to the type of finding as to which level it would fit in. And I'll explain in a second how that worked, in case you're wondering. So we had a variety of consistency measures to guard against bias intra or inter-observer. Monitors were trained in the usual way, and obviously to become monitors in the first place, they needed to have some experience, relevant experience. Temper monitors were present at all visits, which gave some consistency for the study's point of view. We developed an exhaustive, more or less exhaustive categorization system, so hopefully covers every sort of thing that we were expecting to find at sites or that we had found at sites, and guided us in exactly how that should be graded. We had 2 oversight committees. One was a consistency monitoring group to review new findings and decide where they might sit in our categorization system. And the second, more important one, I guess, was the endpoint review committee, which was blinded to the type of visits they were looking at and independent of the trial teams. And they looked at all critical and major findings from all visits and a selection of other findings from each visit. So quite a lot of work for them, but worthwhile. And finally, we conducted a lot of consistency checks pre-database lock, which were mainly just checking that, checking consistency across visits, for example, in a certain type of finding. As I mentioned, our primary analysis was to compare the proportion of sites with at least one major or critical finding in the groups of triggered versus not triggered. We designed the study to have 80% power to detect a 30% difference. For example, if we had 70% of the triggered sites having at least one major or critical finding, we would be able to detect 40 or less % at the not triggered sites. Our secondary analyses or secondary outcomes here are the number of major or critical findings, the proportion with at least one critical finding, and the total number of critical findings, which we would prioritize for obvious reasons. I'll talk at this point about this sensitivity analysis recommended by the Endpoint Review Committee. So while reviewing findings from all visits, the Endpoint Review Committee noted that there were a lot of findings in general to do with consent forms, but in particular in these trials to do with reconsents. In hindsight, it had been felt that there had been quite a lot of reconsent requests that had arisen from relatively minor changes in side effects information. And so the Endpoint Review Committee wanted to look to see if we remove these findings, how do the primary analyses look after that. So I've reached the results. Hopefully all clear so far. So how do we do in terms of matching? These are just timelines to show you when the visits were taking place. Our matching, we are quite pleased with it. So the number of patients, median number of patients, slightly more in the triggered group, but fairly similar. Mean time since first patient, also very similar, and a difference in number of triggers met was 4 to 1, which we think is okay. The range was generally 0 to 6, so this seems okay. I mentioned that we had some timelines for visits, and you can see that there were 2 types of timeline, and both of them are over 90% met, so we think that's pretty good too. If we look at on-site activities, were similar activities undertaken within pairs? Again, we believe so. Some slight differences, so for example, in number of staff attending triggered visits, but not much. And often in any case, that was to do with members of the trial team coming along for training who were, by definition, less experienced. The next thing to look at is a summary of the major and critical findings. So what was our actual prevalence at the end? It's quite a complex table, and hopefully you can look afterwards at some of the detail. I'm going to highlight some of the things that I really want you to look at. In these middle two columns, we've got the major and critical findings of each type, and the original versus the upgrade. So that I mentioned earlier, if there's a lot of major findings, they can become one critical and so on. You can see here that there's a lot of informed consent findings, mostly in the major category, but some critical too. And when I put in the reconsent and original consent, you can really see that there was some problem here to do with reconsent findings. You can see then the detail of some of the CRF findings, the sort of things that were quite common were unreported SAE or unreported endpoint. Overall, this gives us 85% of sites had at least one major or critical finding when we exclude nothing. And of course, this is perhaps higher than we had predicted at the start, but not inconsistent with other recent publications, if anybody's seen the Adamon study paper recently. So here's our primary comparison. The proportion of visits with at least one major or critical finding. When we put all findings in, there's a difference of 7%, which is clearly non-significant. But when we exclude reconsent findings, there's quite a big difference between the triggered and the not triggered of 26%. And this is a statistically significant result. I'll breeze through the secondary analyses as well. So if we only look at critical findings, so proportion of visits with at least one critical finding, in both cases here we do have a difference, which is a reduction from triggered to non-triggered. Funnily enough, exactly the same difference, and it's hovering around the border of statistical significance. And finally, the total major and critical findings by visit type. There was again some difference, as in more major and critical findings at the triggered and versus not triggered sites. We can see, for example, with all findings, we have a median of 3 versus a median of 1 with the non-triggered. We do have statistically significant result in the when we exclude reconsents, but it's worth noting that there's a very small difference between those. Okay, so it's the second part of the results. I mentioned earlier we're looking for other predictors of on-site findings. These were included the most or least useful types of triggers, and then those the analysis of those questionnaires that I mentioned. The data were from those 84 paired visits plus 10 unpaired visits to high recruiters, which I haven't mentioned so far. That's a detail that you will find in the paper when that's ready soon. So what sort of triggers were we looking at? For these analyses, these exploratory analysis, we could say, we combined trigger types from between the trials to boost the power of our comparisons. So the sorts of things that we're looking at that were common to all trials: general concern, which was added manually by trial teams in response to, say, a series of worrying events or worrying contact with the site. The rest of these are all automated ones, so poor CRF return rate, high data query rate, slow data query resolution time. Hopefully all self-explanatory, but do ask at the end if they don't make sense. And then some that were common to two trials, for example, protocol deviations, known protocol deviations, and perhaps the rationale for going to site is that you might find more or that you're generally concerned about their trial conduct. And then low or high SAE rates. The triggers best able to predict on-site findings in our analyses were data query resolution time, with quite striking results. So that's if a site hadn't returned a large percentage of data queries 3 or 6 months after having been sent them, they would trigger for that. Protocol deviation, as I mentioned, is known protocol deviation based on the data we've been sent, and general concern, I mentioned, was added manually. We don't need to go into the detail of that too much. Those are quite useful results, I hope. When we looked at the pre-visit questionnaires, let's start with the Clinical Trials Unit 1. We asked the CTU trial team pre-visit to give us a rating for 6 criteria: overall performance and resources, and then speed and quality of communication and query resolution, just based on their perceptions. Unfortunately, there was no clear evidence that this was predictive. When we looked at staff roles, we asked site staff to tell us who was doing each of these tasks, so attending multidisciplinary team meetings, training new staff, reviewing trial CRFs, discussing trial with patients, pre-screening activities, and completing trial CRFs. And we found this interesting result. So the more of these roles held by a research nurse, the fewer major and critical findings at site. And on the reverse, the more roles held by a principal investigator, the more critical and major findings at site. We interpret that to be some of these roles we wouldn't necessarily expect a principal investigator to be doing, say, for example, completing trial CRFs. And so it's probably an indicator of being under-resourced, overburdened with other things, which might be a risk factor for higher major and critical finding level. So to summarize what I've been through, we feel the actual study conduct met our expectations. In our primary analysis, there was no clear difference between triggered and non-triggered sites, but when we exclude the, that should say, reconsent findings, the discrimination increases substantially. And in our prognostic analyses, a small number of triggers appear of most use, but we do need better discrimination. The clinical trials unit pre-visit assessments don't seem to be useful, but maybe we could develop something a bit more useful in due course. And the site staff activities are potentially useful indicators. To conclude, triggered monitoring as implemented in these trials can discriminate but needs refinement. We might rely less on subjective assessments and develop some more automated triggers, I should say. And we acknowledge that the number of sites with at least one major or critical finding is quite high. A lot of what we should do after this study is actually deal with those things that we found before we do further study. We do believe that the majority of findings were to do with consent, and the non-consent findings were typically isolated and related to source data verification. You might be familiar with other work suggesting that this has minimal impact on robustness of results. What we haven't gone into too much is this importance of the communication role and face-to-face contact with sites that site visits can do, and central monitoring obviously can't so much. We hope that our results, when we write them up, will further inform how we can best do this. So we acknowledge funding from Cancer Research UK and the London Hub for Trial Methodology Research. There's the trial team, and there's the trial email address in case you would like to get in touch. Thanks very much for listening, and I'll take questions gladly.
Thank you, Will. That was really very useful. If anybody would like to put questions, you've got information about how to do it. Please just add them into the chat box, or put your hand up and you'll be able to speak. So it'd be really good to hear from you. I'm sure there's some questions, but maybe I can put the first one while people are thinking about that. Given everything you've learned, Will, from Temper, how much on-site visiting do you now say is necessary in trials, given that it's mentioned in ICH as well?
Sorry, could you repeat that? It broke up slightly.
Oh dear, sorry. Can you hear me better now?
Yes.
I said, given what you've learned about monitoring from the results of Temper, how much on-site monitoring do you now feel is necessary in clinical trials? Where has it sort of left your own position on this?
Yeah. Temper data is possibly, well, Temper wasn't really designed to answer that question. What we do know is that at our untriggered sites, the ones that didn't seem to be of concern, there were still major findings, and in some cases critical findings. So certainly for now, we think that some level of on-site contact with the untriggered ones who don't seem of concern is still worthwhile. my own view from having done a lot of monitoring activities is that both central monitoring and on-site monitoring are can be very useful. We just need to use each one for what it's best at, if that's a roundabout way of answering that.
Yeah. Okay, lovely. Thank you. We haven't picked up any questions from the chat box. I'm not sure.
Question.
Is there one? Sorry, I can't see it. Maybe, Riompa, can you unmute someone who would like to ask a question?
Hi, this is Riompa.
Andrea.
A couple of questions from Andrea, and I haven't unmuted Andrea.
Okay, I'll just read them out then, unless Andrea does want to speak.
Yeah, but Andrea, your microphone is unmuted, so if you would like to speak.
Okay. Can you hear me?
Yes, we can. Thank you. Yes, we can. Lovely.
So I had two questions, if I'm able to ask both questions, otherwise I'll stop and let somebody else go. So in terms of your triggers, you said there was a trigger of general concern. Just wondered if you had a steer checklist when you would expect issues to be escalated, because just general concern has been interpreted quite differently from different people.
Of course. So Temper comes from the point of being quite pragmatic. So I mentioned at the start we didn't try to work out what might be the best triggers before we started. We just used what trial teams would use, and our approach to general concern triggers kind of fits into that scheme. So we let trial teams decide who they would like to apply general concern to. We have their reasons documented. Each trigger meeting would have meeting minutes, and this never happened, but if somebody had a strange reason for general concern, I'm sure we would have flagged it within the study. But it was generally pretty consistent. It would be related to some known protocol deviation that hadn't been captured on the CRFs, but we knew about it. That sort of thing would be a general concern.
Okay, thank you. Do you want me to go to my second question, or do you want to offer to somebody else?
No, yes, please do go to it, Andrea.
Go ahead.
Okay, so I may have missed this, but I just wondered if you could elaborate on what your definitions of major and critical findings were.
Sure. So ultimately we did start with definitions, but ultimately it became about this categorization appendix. So where each finding would sit in there. Broadly, I'd say we'd use the same categorizations that you would see from, say, MHRA. So something like critical findings would be expected to affect results and patient safety to a significant degree, and so on. I don't know if that helps somewhat.
Yep. Okay, thank you.
Yeah. The question from Rian. I don't know if Rian needs to be unmuted.
It depends whether Rian has a microphone or not. We'll just wait for a moment to find out, otherwise I can read it out.
Hi, Will.
Hey.
Hello, Rian.
Hi, everyone. Thanks
Hi
very
there.
much. That was a great presentation. Really nice to see the end results. My question was simply, what were the major challenges in conducting Temper? It's quite a difficult study to do.
Yeah, it is. So I joined about halfway through. Hopefully as some sort of solution to the problems they'd had before. So the main problem, I think, was in recruiting and retaining monitors for this role. People might know that clinical trial on-site monitors can do quite well working for themselves or working for CROs elsewhere, so it was quite hard to keep people. And actually, a general lesson to do with studies within trials. We talk about SWOTs and wanting to be able to do SWOTs, but although we try to refrain from taking up too much of the trial team's time, I should say, sorry, we kind of had to sometimes, so it is something of a burden on trial teams to run SWOTs, I think. It needs extra resource. One final thing I should say actually is compared to, say, a trial in, let's say, imagine an oncology trial where we know what trial designs to use, we know what outcomes to use. This was all quite fresh and new, so it had to be somewhat flexible as we went along. Those things spring to mind.
Okay, thanks. And where do you see, sorry, can I just sneak one other question
Certainly.
in? Where do you see, your future work going now, given the findings?
Yeah, I think there's so much to do in generating evidence in this area, but equally people might be aware of, as I say, the Adamon study, and as well there was another study called Optimon that I hope we'll publish soon. So I feel like we're in a good position to start building on this. Key questions for me are, for example, testing some of the central monitoring processes that people have come up with recently, central statistical monitoring processes, testing those a little more formally, and also trying to work out how best to use on-site monitoring visits to have an impact, which I don't think has always been measured. Just some ideas.
Yeah, good thoughts. Okay, thank you very much.
Thanks, Ruth.
Thank you, Will. There's a question come from Denise Dunkley, who hasn't got a microphone at the moment. And
Yep.
She's asking, Will, if you could let us know about the phase of trial that were included in the study.
Sure. So these were all phase 3 trials.
Okay.
And
Thank you.
I think they would all fit into the medium category if my knowledge of MHRA risk categories is correct. So not high risk trials, medium risk.
Okay.
Yeah.
Thank you. I think, do we have a question from Richard? Is that correct? I can't see a written one, but I think there's a hand up. Will, could you take the slide back showing your contact?
Yeah,
that
sure.
might be helpful for
There you go.
people. Was there any other questions that were coming in? There's no more in the chat, but Will, is there anything that you want to add before we wrap up? Are there any new thoughts you've had or any points you're keen to get across?
I suppose I'd say only that people should get in touch, because I think there aren't that many people looking at these sorts of questions, so we should talk to each other. So please do get in touch.
Okay. Well, thank you.
We've got another question from
great.
Andrea, if you would like.
No, yes, fantastic. Thank you, Andrea. Andrea is asking, is there anything to say about training of monitors or monitoring competencies? Could you talk about that a little?
Sure. So, Andrea, I guess you mean within Temper.
Yeah, so a lot of your findings is dependent on the capability of your monitors going out.
Sure. Yeah.
So there is something perhaps about the variability of the level of kind of experience training that your monitors have had. So you've used between trials and you've used your own monitors as well.
Yeah.
So just if there was anything that you wanted to say about that, because we're currently looking at in Southampton.
Sure. So we had a similar training process. It just so happened that me and another monitor who conducted well over half of the visits between us had experience with these trials before. So we certainly knew these trials, and we have experience and training on monitoring aspects as well as part of our roles. Yeah, so nothing else to say about that, I don't think. I think we were happy at the end that people didn't go to any of these visits without having been through some training process.
Okay.
Which is standardised within our CTU.
Okay, so standardised within your CTU and then the trials that were involved in this study.
That's right. Yeah.
Okay.
Thank you very much.
Lovely. Okay, well, thank you, and thank you particularly for Andrea for those questions. They were all sort of tapping into interesting things. I think it's time to wrap up now, and so thank you very much, Will. And maybe you'll come back sometime in the future when you get those other results coming in. That would be really interesting to be able to put those together. Thank you, everybody. We haven't yet got our next speaker organised, but we're very keen to actually keep these webinars running very quickly, at least monthly if we can. So if any of you are interested in giving a webinar like this, I think they're very useful for us to listen to. Links are available later on for other people to listen to the recordings. and you can use them yourself as links to let people know about your research. So please do get in touch with me at the London School of Hygiene. It's very easy, claire.snowden@lshtm.ac.uk, so it's easy to work out. And I would be very pleased to hear from you if you would like to be one of our presenters. Anything related to trial conduct is of interest to groups such as ourselves. So thank you very much for your attention, and I hope you found it useful, and thank you, Will.
Thank you very much.
Bye.
Bye.